way of looking at how we treat sarcoidosis. There are only really two major reasons to treat sarcoidosis: to avoid danger or to improve the quality of life. So what do we mean by danger? Well, death, everybody would agree that that's a major danger. We had a very nice presentation about death, and you want to avoid that. And then the other complications: respiratory failure, cardiac failure, neurologic disease, liver disease, ocular disease. But frankly, for many of our patients, the reason we're treating them isn't so much a worry that they're going to die, is that they're very uncomfortable from their disease. It may be because they're extremely short of breath, that they have cough, they may have visual loss that could eventually go on to organ failure, that is blindness. They have causing problems with their skin, on their face and such, or they have problems with kidney stones, they may be tired, they have small fiber neuropathy. So these are the things that are quality of life. And you have to keep in mind that if the drugs make your quality of life worse, then why take the drugs? Because we're really treating only for symptoms. There are very few things that we can absolutely say. Unless we think that the person's going to have an organ failure or death, we're really treating to make them symptomatic better. So therapy should be based on how you feel. And so you as the patient have a lot of say about whether you're going to take this or not. So prednisone is always the drug that we start with because there's nothing cheaper and in some ways more reliable and faster than prednisone. It just has a few side effects: weight gain, diabetes, mood swings, difficulty sleeping, thinning of the skin, thinning of the bones, heartburn, acne, infections, glaucoma, cataracts. I say this to everybody, and I try to get it to less than 20 seconds so they can't stop me and ask about all the side effects. But these are the side effects, and they are dose-related, as very nicely shown by Dr. Culver's group. That was a very nice pointing out that the higher the dose, the more the side. The worst thing about prednisone in sarcoidosis is this: that once you put somebody on prednisone and you stop the drug, say after 3 months, there's an 80% chance everything's going to come back. 6 months, 50-50, a year, 30%, 2 years, 25%. Well, in general, in sarcoidosis, about 25 to 30% of patients will have disease beyond 2 to 5 years. So in most patients with sarcoidosis, they do get better within the first few years. So prednisone probably doesn't get you over the disease. It doesn't cure the disease. It just makes you feel better. So it's no different if somebody comes in my office with a broken arm. I give them a pain pill, they feel better, until the pain pill wears off. And they have to keep taking the medication until they finally heal their arm. So prednisone is really not a cure, and every other drug I'm going to tell you about is not a cure. They're medications that make you feel better. You can argue about whether they're making you feel better or not, especially the longer you're on them, especially prednisone. Now, I've been a very big advocate of drugs other than prednisone for many years. That's been most of my research for the last 30 years, is developing other drugs. And frankly, I've just stolen these drugs mostly from the rheumatologist. Why? Because one is never on the right dose of prednisone. If you're feeling well, you're on too much prednisone. If you're doing poorly, you're on too little prednisone. And I'm afraid for most pulmonologists, we are still in that trap zone, because that's the only way we think about prednisone in sarcoidosis. For many of us, we don't get enough into the next level, which is to try to avoid steroid side effects. And this is a study from Marjolein Drent. This is, if you can read it, which is a little out of focus, this is in Dutch. This is a worldwide option of what we should go next to, which is to go to these cytotoxic drugs. So this is a algorithm that we developed and people looked at. So if you can get down on your dose of prednisone, as mentioned before, 7.5 milligrams, 5 milligrams, maybe that's the dose, just stay with that. And in our clinic, that works out to about half the people who are on steroids. We can get to that dose and control them with that, maybe with a little bit of some other things. But if you're not able to do that, then we talk about, I refer to these as the cytotoxic drugs. These are chemotherapy drugs, some of them, methotrexate. Some of them are drugs that came from the transplant area, azathioprine, mycophenolate. And these drugs work by killing some of the inflammation cells. Prednisone kind of makes them drunk. They don't work as well, but they're still there. So when they draw your blood, you still have plenty of white cells. If you take these drugs and you draw your blood, if you have too much drug on board, your white cells will be gone. In cancer, methotrexate, the dose for cancer patients is 150 to 1,000 milligrams. In rheumatoid arthritis, they use 25 to 50 milligrams. In sarcoid, we use 5 to 10 milligrams. My wife's an oncologist, a cancer doctor. We started our clinic, and the first drug we started using was methotrexate. And one of the things we found out pretty quickly was that sarcoid patients were more susceptible to lowering their white count with methotrexate than, say, rheumatoid arthritis. So we use lower doses than the rheumatologists do. They always think of me as using the very wimpy dose when we use this. And you have to be careful. We have patients on as little as 2.5 milligrams, and they can do well with it, but you have to monitor their blood work. So when you're going down this pathway, and you're deciding that you're going to go to the next drug because you don't like prednisone, it's a question of which one of these drugs do you want to use. And this depends a lot on your own physician and yourself and what you feel about it. Your physician will have their own mind about what they're used to, what they've used in the past, what they were trained with, but you also have your own side effects. So this is just kind of a way of looking at it. The major side effects for all these drugs include nausea. You can lower the white count. You have to get a blood count. We usually get it every 2 to 3 months. There's effects. It can affect the liver, so you have to monitor the liver function test, bloating and diarrhea, or risk for skin cancer. These are kind of the major ones that I think about when I'm looking at this drug. So methotrexate, as I said, not surprisingly, is our drug we usually start with. Well, we've also used leflunomide, which is a drug many of you probably have never heard of. It was developed by the arthritis doctors because it doesn't have as much nausea as methotrexate does. Now, I've got these as 2 to 3 plus, but these only represent around 5% at most risk for getting it. For the most part, patients tolerate these drugs very well. So when I tell you we're going to start you on drug X, Y, or Z, the chances are you'll be able to stay with that drug. You may not be able to, but the chances are pretty good that you will with any one of the particular drugs. Physicians are always looking at odds, they're always trying to benefit, make sure that we don't run into things. You brought up earlier that worry about pulmonary toxicity. That occurs less than 5% of the time with methotrexate, and we don't see it very often in lung disease, so most of us are comfortable giving methotrexate in patients with pulmonary disease as long as we monitor their pulmonary function. We'll look at their lung tests, look at how their breathing is. Obviously that sounds difficult if you're having a lot of problems with your breathing. If we're worried, we stop the drug. But for the most part, you're going to tolerate the drugs. It's just a matter of which one you feel the best with. So again, remember, you're only being treated for how you feel. So if you feel miserable and nauseated every day, you take your Imuran or your methotrexate every week, then you can go on to another drug. So this is nice that we have 4 options, because all these drugs take about 6 months to kick in, and they only work 2/3 of the time. That's the average way I think about it. So when you're sitting there wondering whether you're taking this pill every day for the next 6 months, is it really making any difference? So these are the side effects. You try to mix and match which ones you are. And I have over here skin cancer. That's a pretty low risk, but it's more of a risk with these 2 drugs in the transplant arena than it is for these 2 drugs. And it may be in the transplant arena because this is mostly where it was seen in transplants, and transplant patients are on a lot of drugs, some of which also can increase the risk. So we're not clear whether if you just have sarcoid, whether there's even an increased risk for skin cancer. There's just not enough data. But this is kind of how we view it, comparing one versus another. So what happens if that doesn't work? Most of you in the room have probably been on prednisone, have probably already been on one of those drugs I just showed you, and I suspect there are a fairly number of people in the room who've already said, well, that didn't work, so what was next? So this is the next drug that we talked about, failure drugs. Infliximab, also known as Remicade. Adalimumab, also known as Humira. Humira is sold much more frequently now in the United States than Infliximab, and so that's why you hear much more commercials on television about Humira. If you think about it, the reason there are a lot of commercials must be because they make a lot of money. They make a lot of money because it costs a lot of money. These drugs are very expensive. And for any of you who've tried to get these drugs, you realize that they have some problems with them. We like Infliximab because it seems to be better. It works a little bit faster. It seems to have a higher rate of response. We've shown this, and other people have shown this for sarcoidosis, for various forms of disease. So, but adalimumab is certainly a good alternative. So it's something that you can use, and again, it depends a little bit on you and your physician, which of the 2 drugs you would use. And I'm afraid it also depends on what your insurance company will say, because they're the ones that actually have the ultimate decision. So in the way I think about when to use these drugs is that who's it really going to help? Are there some markers, meaning it doesn't rule it out, it just only helps us with this positive? But if you have that, or you have this high level of the soluble IL-2 receptor, boy, that's a good marker for that this person's going to respond well to treatment. The third one was the PET scan. You saw some nice examples from Dr. Miller in the cardiac arena, and we do this in other parts of the body, that when the PET lights up, the more inflammation you have, the more likely we are to think that the drug is going to work. It's been shown now in the lungs, you've shown examples of seeing it in the heart, so your doctor may try to get a PET scan, or try, again, one of those expensive tests that aren't usually covered by the insurance, so they may not be able to get it. This is a genetic polymorphism that has been studied in the rheumatology literature, and there's one study in sarcoid population. It's not been studied any further right now. We are launching a trial to look at this, and maybe this would be somewhere down the road that we can get it, because in the study that was done, 95% of the patients who had the GG polymorphism, just the type of gene they had, just like if you have sickle cell, you can have sickle cell disease, you can have sickle cell trait, or you can be normal. If they were GG, they had the normal pattern. They didn't have any sense of this other G, which is A. They had not over 90% chance of that. If, on the other hand, they were AA, that means they didn't have either one of the G things, they had a less than 30% chance that they responded to Remicade. So you can imagine that would be a nice test to do routinely. We just simply haven't done it because we haven't proved that this goes on outside of that one center in Holland. Some things that we do know about that work very well with sarcoidosis: lupus pernio, neurologic disease, and eye disease. What is lupus pernio? I'm sure we have somebody in the audience that can show us an example of lupus pernio, because this is a chronic, stable form of the disease that stays on forever. This is kind of these lesions. You've seen a couple of the pictures on the nose, the bridge of the thing. Not to confuse you, lupus means wolf, okay? So lupus erythematosus is what lots of people refer to as lupus. That's just red markings on the face. That's a form of arthritis, SLE, lupus erythematosus. Lupus pernio means these maculopapular lesions that some dermatologist said, that looks like a wolf marking in my patient's face. And that's what he called it. I like Hutchinson's description. He called it Mrs. Mortimer's malady. But that was from the 1880s and never really caught on. So this is a lady that had been on pretty much everything. I had treated her with things including thalidomide and steroids and Imuran and things like that. And this is the best I could do. I gave her infliximab. This is by the third month. She was willing to let us publish this because this is the paper that really launched infliximab in sarcoidosis. We actually saw improvement by 2 weeks. So you can imagine how this made people pretty enthusiastic about the drug. And over the years, this has been shown to one of the things that routinely a dermatologist seeing something like this with lots of inflammation, lots of redness, will say, well, gee, if we could give infliximab to you, that will get better. So what are the limitations? Why aren't we just talking about it in everybody from the beginning? Well, besides the fact that it's expensive, at least 10 to 20% of patients will develop severe allergic reactions to the drug. I'm not just talking about a little rash. I'm talking about anaphylactic reaction, can't breathe. This is always a worrisome thing, and it can occur anytime you're taking the drug. It doesn't occur just if you get by the first few doses, you're home free. So we don't allow patients to get their infliximab at home. They have to come into an infusion suite where the nurses and somebody around, so that if they do get sick, they can be immediately transferred over. So that increases the cost. If you get past those two things, so any of the anti-TNF agents, that's not only just infliximab, but also adilimab, which is Humira. People are using, we talked about etanercept or Enbrel, which doesn't work as well, but we'll talk, these drugs all have the same bottom side effects. Increased rates for infection, especially tuberculosis. Why TB? Well, tuberculosis is another one of those diseases that causes granulomas. So if any of you have been exposed to tuberculosis in your lifetime, unfortunately you have a risk that tuberculosis could come back if you break down the granuloma. Well, infliximab is a great drug for getting rid of the granuloma, so therefore you run the risk of your tuberculosis coming back. So if you're going to take infliximab, Remicade, you have to be tested to find out if you've had tuberculosis in the past. If you do, some of us won't even treat you with the drug because we're so nervous about it. Others will treat you for TB and then put you on the drug. But that's a big risk. And when you're on the drug, you have to worry about other infections. You can't use it in people with bad heart failure. That's a big limitation here, because as Dr. Miller will tell you, boy, this would be a good drug to get rid of those granulomas in the heart. We don't know quite how it does this, because the study that was done was they took people with bad heart failure and put them on infliximab for their bad heart failure. Why? Mild to moderate heart failure, infliximab helped them, made them feel better. Severe heart failure, people on the heart transplant list, they had an increased risk for sudden death if they took the drug. The company stopped the study, put that in the box, and never is going to look at it again. So we don't know why was there a group of patients who did worse. There have been people since that time who've treated some patients with sarcoidosis with infliximab. And I have to admit that I've done this now, but hopefully that part is going to be clipped out of the recording, because we really are still very anxious about giving it to people with bad heart failure. And there's a big, what's called black box warning on the box of infliximab that says do not give to people with bad heart failure. You shouldn't give this to people who've had cancer. Why? Because infliximab is an anti-TNF, and TNF means tumor necrosis factor, meaning it's the body's defenses against cancer. It's a very primitive defense, but it is effective in some degree. So if you give somebody who has, say, stage 1 or stage 2 breast cancer and infliximab, they run the risk of suddenly having wildly disseminated cancer through their body. My wife's the oncologist, so we never give it to anybody with a history of cancer. So we avoid that at this point. There was a concern that there will be an increased rate for developing cancer because of this drug. And that has been true in patients with conditions called Crohn's disease, another inflammatory disease where this drug works very well. But it turns out Crohn's patients have a higher risk for having lymphoma, and it's felt that maybe that's the case, because in rheumatoid arthritis, the only information that would suggest is that the increased risk is only for skin cancer. So something that we keep in mind, because people are often on this drug now for years. It has only been out for about 15 years, and my longest patient, the one I just showed you, she finally stopped the drug after 14 years. So we don't have a lot of people who have 30 or 40 years of experience. And I hope that all of you in this room are going to live another 30 or 40 years, because hopefully you're not going to die from your sarcoidosis, and we don't want to kill you from the drugs we give you. There's a risk also that's rare, probably 1 in 10,000 to 1 in 100,000, that these drugs can actually cause a sarcoid-like problem. This is not from the sarcoid literature, this is from the other literature, like rheumatoid arthritis, or psoriasis, Crohn's disease, that every once in a while a patient will develop a reaction that looks just like sarcoid. In our patients, we just say, well, that must mean they're not responding to the drug, so we move on. So, but you got to keep that in your back of your mind, because again, this is not the perfect drug. We don't have the perfect drug. So I just will stress in this slide that all these drugs are not equal. The insurance companies like to say they're all equal, but they're not all equal. Adalimumab doesn't seem to be as strong, and maybe only because it just takes longer to kick in. A study from our case, looking at it retrospectively a few years back, we showed that it took up to 6 months rather than in 6 or 8 weeks with the infliximab. And Etanercept, or Enbrel, really doesn't seem to work very well. Yes, there are a few case reports. We did a double-blind placebo control, meaning half the people got drug, half the people got placebo for eye disease, and we showed no benefit over giving just salt water. Another study from the Mayo Clinic where they just took patients with advanced disease and gave them Enbrel, almost none of them responded to the drug alone. So this drug doesn't work very well. And when I see a patient who is on Enbrel for their sarcoid, even if they're doing okay, I still suggest that they get switched over to either adalimumab or infliximab, because I think it's a stronger, better drug, if their insurance will allow them. Golimumab, Symphony, is another one of the anti-TNFs, and we had great hopes for this. We did a large trial that was recently published that showed there was no benefit. Now, I think the reason there wasn't any benefit is because we gave a very low dose, relatively. And these drugs seem to work. The higher the dose, the more likely they are to work, which is why infliximab is probably the dose we give is the highest relative to all the other ones. And I think that's why it works. Now we're in 2017, and we have a big problem coming up, which are called biosimilars. I don't know if any of you run into this yet, but a few years ago, when they realized that drugs like Humira and Remicade were making fortunes for those particular companies, the generic companies tried to come out. You can't make a generic of what they're called biologic agents, because it's just kind of like, it's how you make your cake. It's just it's got a little secret recipe. But you can make something that looks very much like it, and that's what's called a biosimilar. And there have been several biosimilar studies out. The last count, I have a slide with all the biosimilars, so it's about 25 or 30 studies. None of them involve patients with sarcoidosis. And you can see our anxiety here because we already showed that the drugs are different that are already available. So we don't know whether this is going to be a problem. We don't know, for example, is infliximab going to work like the biosimilar for infliximab? Because we already know that golimumab didn't work. So we're kind of nervous about this. What they're doing in Holland, where they have already been encountering this problem about 2 years ago, is they decided to test any of their new cases on the biosimilar and see what happens, versus their old cases that they've been treating and they kept them on the same drug. So that may be an approach that we're going to try to do in the United States. We're trying to get people interested in giving us that information about database and try to set that up. So even though I have a large clinic, I work with a lot of other centers across the United States trying to get this type of information together. So when we get back to you about whether you should use a biosimilar or not, we'll try to help you with that answer. What else do we have? I'm going to finish up with 2 other drugs that we'll give some data about, and then I'm going to give you about what's the future. Rituximab and repository corticotropin. There's no clock. Oh, won't pass. Okay, rituximab. This is a drug that we got interested in because this is what the rheumatologists use when they can't use Remicade in their rheumatoid arthritis patients. So one of the drugs, this is a lady that had, by the way, all these patients that I'm showing pictures of have agreed, given me signed consent. They want to educate people about their disease and what happened to them. So this lady got on 60 milligrams of prednisone. This is after a few months of taking rituximab. We now have her down to 4 milligrams of prednisone. So it is a drug that can work, but overall it only works about 50% of the time in patients who have failed everything else. So it's not the average person. Somebody asked a question about Acthar gel, repository corticotropin injection. This is the first and only paper so far published in the new era about this drug. It's from ourselves and Joe Barney at the University of Alabama. So this is a 47 patients. That's about 50 patients. You can see right off that a group of those, 40%, dropped out because they couldn't take the drug for more than 3 hours. Couldn't, wouldn't, didn't want to. It's expensive. It's the most expensive drug we're talking about. 2 of the patients had gone on and they died from their disease. I don't think they had any relationship to the drug they died from. They were pretty severe patients that we put in. Most of them stopped because of the shakiness and that you get, and you can get problems with your sugar going high the day of the injection because this drug works in part by making your body make more steroids. So for the 26 to 24 hours after the injection, you're going to get a slug of steroids. In my mind, about the equivalent of 20 milligrams of prednisone. So that's kind of these side effects. But if you can get past that point, got beyond 3 months, you can see that most of the patients either improved or stable. When we say stable, we wanted to get the patients down on their dose of prednisone. That's our goal. Our clinic, prednisone is a bad thing. We're always trying to get people off prednisone. Many of you may like being on 20 milligrams of prednisone, but in our clinic, we like to get people off prednisone. So we always do we're making them stable and down on their prednisone, that's good. There were only 2 out of the 29. So this is an encouraging drug, but it needs a whole lot more work. One of the things, why does it take so long to kick in? How to use it. We just completed 1 trial we'll be presenting some more data on, and there are a couple other studies looking at this drug. So it is something that's kind of in the future. What else do we have in the future? Well, clear, a combination of levaquin, ethambutol, azithromycin, and rifabut. This is a combination developed by Wanda Drake, a wonderful lady at Nashville, Tennessee, at Vanderbilt, and she had shown in a couple studies that this helped with some skin patients and some lung patients, so we're in the midst of a large trial comparing to placebo. We're about halfway through that trial. It's a combination that leads to a lot of side effects, and I'm still not recommending it as a routine therapy because we still are working our way through how to help deal with the sound effects. Elliot Krauser at OSU, Ohio State University, up the road from us in Columbus, has shown, and we've sent some patients into this study using transdermal nicotine patches. Because patients with sarcoid are more likely to be non-smokers, he wondered whether the nicotine was part of that reason. Mesenchymal stem cells is the study we did with Dr. Culver. This was an interesting study. 4 patients treated, 2 of them had a prolonged remission. Unfortunately, the company is not willing at this point to go further back and to do some more studies in that one, but maybe in the future. Vasoactive intestinal peptide, that's a study from the Europeans, Mueller Parno and Andre Postek. Again, kind of waiting for them to come back with their next study. Somatostatin receptor blockade, I think this is a very interesting single report, came out this last year of a new modification for severe disease. I just put this on your thing. Nobody else is doing this. They had to worry that they were going to put these people into total, make their aplastic anemia, their whole bone marrow shut down. So there's some things that need to be worked out on this, but this may be a very interesting therapy for severe sarcoidosis. So keep this in mind that there's something out there. And frankly, I think this has got much more likelihood than stem cells in the near future for sarcoidosis. And finally, there's about to be launched a study of another arthritis type drug already commercially available called Ancora, which they're looking at in sarcoidosis and which we're part of on. So there are several agents that are available for treating the inflammation, a stepwise approach. You've kind of got the feeling that we start with going a little bit and kind of working our way up. I think the steroid-sparing agents really should be used sooner rather than later. And we are way behind the rheumatologists in using this. We don't start most of our patients on drugs like methotrexate at the beginning, and we probably should. And as I said, there are some newer agents being explored. Thank you very much for your attention.